All right, thank you. Um, since I listed two purposes, the first to discuss ACT and psychosis, and the second to consider perspective taking, I'm going to weave those two things together since perspective taking is, or look at perspective taking as one way to understand delusions and hallucinations and disorganized speech and other and negative symptoms of schizophrenia, but virtually all the symptoms seen in schizophrenia or other psychotic disorders. And just starting with schizophrenia, there's no doubt there's some genetic and biological basis for it. So this isn't a competing view with anything to do with biological and sort of structural brain deficits seen in schizophrenia. We know there's disordered glutamate receptors and an excess of dopamine receptors, and we know there's clearly some amount of genetic heritability, especially as well among parents and children and monozygotic twins. But still, what considering perspective taking and other cognitive deficits might do is help us to find treatments. Because although medication is clearly helpful, it isn't helpful enough. Even the best medications, we still see that symptoms persist for 75% of patients who take them. They might be at a reduced level, but they're still present. And also the medications are not without their side effects. And interestingly, and actually very sadly, even when clients adhere to medication and positive symptoms are reduced, you don't see much improvement in quality of life. So it isn't as if the whole story is eliminate these positive symptoms and then people with psychotic disorders will be doing just fine. And one way that perspective taking has been considered for a long time is outside of ACT, and that's looking at the notion of theory of mind. And at its simplest, we can look at theory of mind as awareness that I have a mind and that other people have minds, and understanding, what might be going on in another person's mind. And with that very simple definition of theory of mind, some data about schizophrenia that are put in to this theory are that we see deficits in autobiographical memory. So I don't know my own history, basically. And in paranoia, we might regard that as being associated with a recollection of unusually negative events in one's own history. And some look at negative symptoms as deficits in autobiographical memory, or as being a result of deficits in autobiographical memory. So the negative symptoms of schizophrenia are amotivation, poverty of speech, a lack of interest in socializing with others. And it's easy to see how a deficit in autobiographical memory might especially lead to a lack of motivation, because our motivation to do something comes from a history. And disorganized speech could be regarded as arising from a conditional reasoning deficit and failure to appreciate the relationship between the speaker and the listener's knowledge. So in theory of mind, I don't understand what's in your head. Another related area of research outside of relational frame theory is looking at more positive symptoms, and especially paranoid delusions and attribution biases and deficits in conditional reasoning, where in faulty attributions, where you might get a paranoia when someone's attributing events to the negative intentions of others. And there's some pretty robust research that we see these attributional biases in people with paranoia. Also, they overly attend to threatening stimuli in the environment and interpret neutral stimuli as threatening. And there are a number of therapeutic techniques that are based on disputation, like conducting behavioral experiments to go out and test whether something in the environment is threatening. And with the theory of mind, it's been more basic research than applied research at this point, but the kind of tasks you might have a person do are to show them a scenario or vignette of two people interacting and ask them what they believe the intention of the other person is. And what you find is people with schizophrenia need many more cues before they're able to, let's say, read the mind of the other person. So in one video clip, they show a couple in their apartment, and it's morning, they're getting ready to go to work, and the man comes out with a wrinkled shirt and says, you know, gosh, I'm in a hurry today. Says to his wife, you know, I'm in a hurry today. And the inference we might get is that what? What does he want her to do? I'm sorry, I can't hear you guys right this moment, but the iron his shirt. So that would be the least amount of inference. He just says, gosh, I'm busy today, and he's holding up a wrinkled shirt. And then in the next step, he might say, wow, this shirt is really wrinkled. And then he might say, oh, this shirt is really wrinkled and I don't have time to iron it. And finally, say, will you iron this for me? And the person with schizophrenia, you have to get all the way to, will you iron this for me, before they get what the other person wants. So that's kind of a typical theory of mind test for identifying deficits in people with schizophrenia. This line of research has also led to interventions when we consider self-esteem in schizophrenia, which I'll get into more later about how that's related to perspective taking skill. But Richard Benthall is the name most associated with theory that delusions are a defense against low self-esteem, and that basically the delusional belief functions to maintain higher self-esteem. So with a paranoid delusion, instead of I'm a failure, which would lead to low self-esteem, you might have other people are out to get me, so my failures aren't my fault. Or with grandiose delusions, instead of I'm a bad person, I'm a good person. So it's a defense against low self-esteem. Kind of interestingly, in very early Freud's theory was that delusions were a defense against homosexuality. And that's very typical Freud, of course, to have everything to do with sex. But it became something like, I'm not a homosexual, he is, and he's interested in me. Or erotomatic delusions, I'm not in love with him, he's in love with me, and so forth. But this, I think this idea of delusions as a defense against low self-esteem has something to it. And Richard Benthall's group, I'm forgetting the name of the first author on this paper, it's a very recent one, looked at the relationship between low self-esteem, paranoia, and emotional avoidance, and found that emotional avoidance was a way to defend against low self-esteem, and that it doesn't work very well, and that emotional avoidance increases paranoia. And his data looked at a community sample, so it wasn't particularly individuals with psychotic disorders, but his theory is that it's more cognitive than anything to do with relational frame theory, but it to me anyway makes some sense that scanning for unwanted thoughts is kind of effortless if we look at thought suppression and experiential avoidance. But it takes a lot of effort to do something else. Once you identify unwanted material, that takes a lot of effort to get rid of it. We have to do distraction, we have to focus on something else. And his theory is that this effortless scanning for unwanted material is going on continuously. But once we get stressed, the more effortful avoidance strategies break down. And one consequence of being kind of overloaded cognitively is that we're more likely to make faulty attributions. And when something in the environment goes badly, we're more likely to attribute it to the actions of another person, so to make a paranoid interpretation, in other words, when we're stressed. And so he looks in this paper at the relationship between stress, paranoid thinking, and experiential avoidance, and it comes out pretty strong. It's a very neat little study where they use structural equation modeling and had a very large N. So stopping there with some of the other approaches, now looking at more relational frame theory and ACT. If we look at perspective taking, the three types of deictic frames are relating me to you, here to there, and now to then. And we always behave from the perspective me, here, now. Only through direct training do we come to appreciate that others have a different perspective, or that we can relate events now to events that haven't happened yet, or make predictions about the future, or relate events to the past. But it's demonstrative. We can't teach a skill verbally. We have to demonstrate it through social interaction with others. Deficits in theory of mind would also be related to deficits in perspective taking. And there is evidence for limited or poor perspective taking in persons with psychotic disorders. Dermot Barnes, or McHugh and Barnes-Holmes did some research a few years back on a developmental profile of perspective taking skill, looking at normally developing individuals, and then they also looked at children, and another author extended this research to persons with developmental disabilities. I'm forgetting the name of who to cite there, something in JAB a few years back. But you see that as cognitive or intellectual deficits increase, perspective taking skill decreases. And you see in children a clear developmental profile that the ability to relate me to you develops first. So it's easiest and first we develop the ability to relate me to you. And then we see relating here to there. And last, we see relating in terms of time, now to then. And I looked at a small sample of persons with serious mental illness with and without psychotic disorders. And those with psychotic disorders did worse on a perspective-taking questionnaire. And the questions are along the lines of an easy question is, I have a red brick and you have a green brick. If I was you and you were me, which brick would you be holding? And they get increasingly complicated, where a more complicated question might be, I'm sitting on the black chair and you're sitting on the blue chair. If I was you and you were me and here was there and there was here, where would you be sitting? Normally developing adult will get about 70% correct on those more difficult ones. In the more difficult ones, it got close to random responding, like just above 50%, with the sample with psychotic disorders. And when we consider the deficits seen in schizophrenia, it's not that hard to see how they might be related to deficits in perspective taking, where we could see negative symptoms resulting from a failure to appreciate the social consequences of your own behavior. So we see things like poor hygiene, poverty of speech, and if you're not really aware of others' perspectives or attending to the fact that they have a perspective, it becomes less important to engage in socially appropriate behavior. When you think about just how very much of our behavior is for no other reason than potential negative social consequences. And in fact, I like to regard institutionalization generally as resulting from a lack of exposure to the social consequences of behavior. A little exercise is just to imagine yourself walking into class and you haven't showered for a week. You haven't combed your hair or brushed your teeth for a few days. You're wearing dirty clothing. Maybe they haven't been washed after half a dozen wearings. And imagine how your classmates would react to you. And probably not very good if they'd probably keep their distance. And maybe if they're a friend, they'd say, you know, what's going on? Are you okay? But in an institution, it might be your neighbor looks exactly the same, or your neighbor doesn't care and doesn't react to you. So we could see a lot of institutionalization as just arising over a history of a lack of social consequences. And with psychosis, on top of that, you might have a deficit in the ability to even appreciate the social consequences when they are present, when they are imposed. And then we also might see, that's looking at the relationship between me and you, is the failure to appreciate social consequences. When we get a failure of relating now to then, we can see a motivation or a volition, that there's a failure to attend to the relationship between my behavior now and the future consequences. Or in the past, even how past events might lead up to the behavior that's occurring now. And how all of these could lead to delusional thinking. Like delusions of reference are almost literally problems with here and there. That the individual is attributing something there to events that are taking place here. So both positive and negative symptoms of schizophrenia can be understood in terms of problems with perspective-taking skill, and also with errors in conditional reasoning. So just if-then statements, where there's well-documented research showing a deficit in problems with conditional reasoning, which would also be related to delusional thinking and possibly to negative symptoms. And hallucinations, same thing. It's perceiving, having a perception in the absence of a stimulus that would normally produce that perception or result in that perception. And is that a failure of attributing a voice to one's own behavior? You know, is it a problem with perspective taking? Or is it a conditional reasoning, where Maher and Benthal and Kinderman look at hallucinations as a problem of conditional reasoning, where we see, or rather, I'm sorry, that, well, yeah, it is a problem with conditional reasoning, that hallucinations are bizarre, that if I'm hearing voices and I must think they must be caused, and instead of thinking they must be caused by schizophrenia or they must be caused because I'm crazy, instead the person says I must be hearing, I'm hearing voices, so someone must have planted a radio in my head. It's kind of faulty conditional reasoning, and faulty perspective taking about how this condition might arise. One thing you could add with the faulty conditional reasoning is also looking at grandiose and paranoid delusions, where I find any type of delusion really fascinating, just in how is it that a person can come to believe something when they don't have a history that supports having such a belief. So how can someone believe I'm the president when they don't have a history consistent with actually being the president? And you could look at faulty conditional reasoning plus Bental's theory of defense against low self-esteem, and it might become something like the president is good and I'm good, therefore I'm the president. Or that same idea like Bental's, that I'm not a failure, people are out to get me, where you could combine, if you have someone with both the deficit and conditional reasoning and poor perspective taking, where they don't see that you, the listener, knows that they don't have the history to be president. It's not that hard to see how delusional behavior might arise and delusional beliefs. And now just briefly moving on to treatment approaches with this in mind. Although it might at first glance sound like ACT would be difficult to apply to this population, if you consider delusions and hallucinations as continuous with more ordinary thought processes, it's much easier to see. And then we would look at that the problem isn't content. The problem isn't that we need to get rid of delusions or hallucinations. It's that the individual needs to learn to relate to that content differently. So instead of challenging delusional beliefs, we look at the action person takes when delusional thoughts show up, or how they respond to their hallucinations. And in my experience, some individuals with psychotic disorders have some insight into the delusional nature of their thoughts, where the problem might not be a matter of content, but you don't have to deal with diffusing from content. That person already knows this is delusional. And instead, what they might say is, when I get delusional, then I can't function. Or when I hear voices, then I get upset. And that person's actually much easier to treat, because you don't have to work on diffusion from content. They're sort of already there. But with a lower functioning client, you might have to go even further back to diffusion techniques we use with any content that this is a thought. I'm having the thought that, and we can use these same techniques with paranoid thoughts, grandiose thoughts, that we would use with any client presenting with any problem. And to do that, we have to consider delusions as continuous with normal beliefs. Kelly Wilson likes to point out how different is the thought like, I'm no good. How is that different from a delusion? How is that different from I'm the president? And one way where maybe it's different, and this is where Bental looks at more philosophically, it's very difficult to prove that these beliefs are not true. We might be able to prove that someone's not the president, but other thoughts like I'm no good get a little harder. And proving that others aren't out to get you is also a little harder. And we see lots of continuity. Probably if you scroll through your own circle of friends and acquaintances, you probably know some people who you might describe as kind of paranoid. They're not delusional, but they do think that others have ill intentions. Or you probably know people who are kind of grandiose. They might not think they're the president, but you might use the adjective grandiose to describe them. And these are on a continuum. And if you look at somatoform disorders and OCD and social phobia and other phobias and depression, then there's thoughts and beliefs that are common that we don't seem all that different from delusions when you start to really think about it. Like the person with OCD who is worried about being contaminated. Is that a delusion? Maybe not, but it's certainly on a continuum with delusion. And I'm emphasizing that just kind of to make the case that delusions really aren't so different. At first glance, they seem like something radically different from other sorts of thoughts in maybe our more worried well clients or clients with less severe disorders. But they're really different in severity, not in kind. We'll start ACT with diffusion and with accepting these unwanted thoughts, or more often in hospital settings. I'll start this kind of intervention with values clarification, and this is something I like to recommend with clients who are less voluntary. With clients with psychotic disorders, they're often completely involuntarily, they're hospitalized. They're not coming to treatment saying, I can't stand these thoughts, or I want to feel different. They don't want treatment at all. And I find it useful in that case to start with values, because we can say, okay, so long as you're stuck here and we have to meet, what do you want your life to be about? And really start with values. What would you like to see different in your life? Is there anything you'd like to improve? And start there to build motivation. And I think that's equally true with clients I describe as semi-voluntary. So maybe clients who are court-ordered for substance abuse or anger management, adolescents, one member of a couple where you see couples or families in therapy. But with less voluntary clients, you might start with values, because you kind of get to what's in it for me? Why should I come to this therapy session with you? You can say, well, what is in it for you? Let's look at what do you want? Values with clients with psychotic disorder is more or less difficult depending on how institutionalized the person is, maybe how long they've been in the system. Early intervention is identified as being strongly related to good outcomes in schizophrenia, and I think it's partly because the person hasn't been derailed. They're early in the process of recovery and maybe not too far derailed from the goals and values they've held. But clients more institutionalized might have not considered their values in years, where we might see a client who, let's say, I'll give an example from when I've worked in mental health institutions. I think this is less likely to happen today, but 10 years ago, we would write the client's treatment goals and have them sign their treatment plan. That's certainly not them exploring their own values. It's us saying, here's your goals. Will you sign on? So we might start, instead of values clarification like we do with a higher functioning client, we might ask, what are your goals? What do you want to do? How do you want to spend your time? If you could change something about your life, what would you change? And then from goals, we can often extract values. Just one little example I've often used is a client who said she wanted to be a veterinarian. This was a client who was in her 30s, had dropped out of high school, so becoming a veterinarian was a very long ways away. So we went through the steps of what she would need to do. Okay, you need to get a GED, go to school, get a bachelor's degree, go to veterinary school, and she came back with, I just want to help animals. And we got that as a value, and she got a job working in an animal shelter and was very satisfied with that. So we might look at goals, and instead of just dismissing them, see what values we can extract from them. And also, this is more anecdotally from other clinicians using ACT in the treatment of psychosis. They say when clients start talking about values, talk about delusions and hallucinations goes down. And there's data that clients with schizophrenia attend more to their own thoughts than others do. And I wonder how much of that is because you're somewhat socially isolated and not engaged in a whole lot of meaningful activity. Like, I think any of us, if you were just sitting at home all day, smoking cigarettes, watching TV, and drinking coffee, which is the day of a lot of people with schizophrenia, you probably tend to your own thoughts more too. Where if you're out in the world and doing things, you might attend less to that. So you find actually that delusions and hallucinations become less problematic just by getting engaged in other activities. And also, when we can identify some values, it builds willingness to accept unwanted thought content. So a client who gets a job because he wants to be self-supporting might be more willing to learn how to accept paranoid ideation than the client who doesn't have a value. He'll just quit his job or stop showing up to work. And let's see, a lot of the, kind of in general, a couple ways to adapt ACT from a more general protocol we might follow is just focus on simpler metaphors and shorter exercises, do more repetition. You might have a shorter session, like maybe 45 minutes and no more than that, rather than going a little longer, or spending 15 minutes of the session reviewing the previous session and 30 minutes of new material. And it's in an inpatient setting, what I like is that you can have kind of the dosage is frequent, where you could do daily sessions with a client instead of once a week. And I think we need to also just be careful about what exercises we're doing. Like taking your mind for a walk is a great one, but we want to make clear that this isn't to simulate voices. But it is a good opportunity to experience diffusion from what you're hearing and being able to go on in a valued direction. And if we're doing Joe the Bum, I would never do that with a client with schizophrenia, because most often they are Joe the Bum and they can't even relate to it. They haven't been to many parties lately. So we want to think about what exercises we're using. And then finally, we want to look at our own stigma as clinicians. It's another kind of robust area of research, is looking at therapist stigma towards their own clients, and also related to that, institutional barriers, like getting other clinicians on board, since so often people with psychosis are participating in a multidisciplinary team where it's not like you're just the lone wolf clinician working with them. So that's all I have to say in opening. Oh, cool. Wow. Yeah, and that's great. Like, because Bentall is one of the biggest researchers in psychosocial treatment of schizophrenia. He worked on cognitive therapy for schizophrenia. Hmm. I think that's a great question, and partly an empirical question. I don't think we have an answer to that yet. And with the folks doing the theory of mind work are probably a little ahead, where they employ some of this as perspective taking skill as skills training to look to see if there's an improvement, but more in social functioning. And I think, and it's not really an answer to your question, but it's maybe another question. But what is interesting to me in RFT research would be looking at the relationship between conditional and conditional relating and perspective taking. And like that word "if," I think is sort of interesting, where we look at the conditional relating in if-then statements, but a lot of our perspective taking involves if-then reasoning as well. So we might even have to go, and where I guess I'd want to know, is conditional relating necessary for perspective taking, or vice versa, or are they mutually enhancing or mutually exclusive? Because we do see cases in like autism, where we might see someone who has fantastic logical reasoning skills, but they don't do perspective taking very well. So it doesn't appear that with just that one example that maybe it's necessary, but it would seem that they would go together somewhat, that someone who's good at conditional reasoning would be better at perspective taking, or someone who's better at perspective taking might do better at conditional reasoning tasks. And I'm not sure if diffusion, I don't know, could you do diffusion with someone who has poor perspective taking ability? Where there's a concept of thought-action fusion that is more discussed in OCD. Where it's like the person believes that thinking it is the same as doing it. And I'm not sure that's an error of perspective taking, because they do know it's me, and they do know it's here, but they see like thinking a thought as having the same consequences as doing the behavior. Like you most often see that with people who have thoughts of harming someone. So they might be obsessed with the idea that they're going to kill their children, for instance. And then the thought-action fusion, like thinking it is just as bad as doing it. And is that a failure of perspective taking? Or is that, if we tried to understand that in terms of RFT, is it conditional reasoning? And I'm not sure what the answer to that is. But with low-functioning clients, you aren't going to get as far, like with the observing self. At least that's been my experience. And as delusions get more entrenched, you definitely need more sessions. So some skill repertoire is being built up, and as the symptoms are more severe, it does definitely take more time. Like the intervention in the Bach and Hayes 2002 study was only 4 sessions, and it was much more effective with clients with hallucinations than clients with delusions. And that doesn't mean delusions can't be treated, but it takes more than 4 sessions, because you are doing more repeated practice, and I think perhaps there are different deficits. Well, we don't know for sure, but what we speculate is that there was not actually an increase in frequency of hallucinations, but there was an increase in willingness to report them. Because anyone who is savvy in the mental health system, any client who's savvy knows that if you want to get out of the hospital, you deny having hallucinations. The two things you don't want to say are, I want to kill myself and I'm hearing voices. Those two things keep you in the hospital. And ACT is, I think, something new for most clients, that they haven't been in contact with many treatment approaches that say, oh yeah, you're hearing voices, okay. Instead, it's we got to get rid of those voices. So if you're seeing as the problem isn't the content, you're more willing to not only to have it, but maybe to report it. But that's speculation. That it wasn't actually a decrease in the incidence of the symptoms, but an increase in or an increase rather, but an increase in reporting them. Yeah. Mm-hmm. Yeah. Yep. You find delusional beliefs too. Like beliefs really hard, hard to predict. Yeah. Mm-hmm. I wonder what the normative data for particularly delusional beliefs are. No, in hallucinations, it's usually considered, when you look at the literature on it being continuous with normal experience, they look at the things like the hypnagogic hallucinations, or one experience probably a lot of us have had. I know I have, where you hear your name being called, and then there's nobody there saying your name. And I don't mean when it is someone saying your name, but they're talking to someone with the same name, but we actually hear our own name. And in other disorders, we see hallucinations, like when we see depression with psychotic features most often, and in those instances, it's almost always a voice like basically criticizing the person, and they're more easily able to identify it as their own voice. So that might be an example that's sort of on that continuum again, from completely misidentifying the voice. And with delusions, I think it's hard to know. One of my graduate students is working now on a large project using the Peters Delusional Inventory, which is normed for both normal and clinical samples. And an initial concern, her dissertation research was by the committee was, will you get, since it's a community sample, will you get a high frequency of delusional thinking? And actually the answer is yes, where she evaluated after her first 100 subjects, and a pretty high percentage report they endorse at least one statement. And the Peters Delusional Inventory, this is the 21-item version, is 21 common beliefs, like that people are out to get me, I have a special relationship to a deity, I possess some special power. And then they look at the degree of conviction, the degree, so we get like a believability rating, distress, and whether this interferes with functioning, whether this belief interferes with your functioning. And just the normative data in norming this instrument in community samples says that, yeah, these symptoms are pretty normative, but they don't seem to interfere with people's functioning. And some argue that it's in schizophrenia, the negative symptoms are actually the more problematic ones. That a lot of individuals with paranoid schizophrenia in particular can function fairly well once the delusional beliefs are dealt with, whether that's by medication or cognitive therapy, CBT, ACT, whatever. But that it's the negative symptoms that are more entrenched. And medication too, it seems to affect the positive symptoms, but not so much the negative symptoms. And that maybe those negative symptoms, which might be also related to deficits in conditional reasoning and perspective taking and so forth, are the more entrenched symptoms, or are more associated with dysfunction. And in fact, when you look at delusions in people without schizophrenia, like in delusional disorder, you don't find a reasoning deficit. So that does seem to be a difference between the groups. There doesn't seem to be an inherent deficit in conditional reasoning ability or perspective taking ability. So that might be just that conditional reasoning or perspective taking deficits are one path to delusions. I think that's interesting. Yeah, the data I'm aware of is where basically your outcome is don't talk about it. Like it's not let's get rid of your voices. It's just don't talk about your voices. But yeah, you'd have to attend to it. Am I hearing voices now? Am I, it's almost like a thought suppression exercise. Don't think about a white bear. So that's an interesting question. I don't know the answer to it, but I could see that. That type of intervention might lead to attending to your own thoughts more. And I think a part of it, the angle I was looking at it was that it's just a lack of other sources of stimulation. That when you reduce other sources of stimulation in the environment, your own thoughts become more stimulating, so you attend to them more. But I could definitely see interventions of various types contributing to attending more to your own thoughts. Because a lot of the disputation requires looking at your own thoughts and in order to refute them. So that's, I think you might in some instances, kind of depending on the particular mental health setting, I can think of a very positive example in one of the state hospitals in Indiana. They're practicing ACT quite extensively, and they've gotten the whole staff on board. And that definitely seems to make a positive difference. And it probably depends on the particular institution and who all is involved in the treatment of the individual and how lengthy it is. You know, where in one example of a client who was hospitalized for months, which many places are no longer going to keep people in the hospital that long. She had entrenched delusions about paranoid delusions that a neighbor of hers had killed someone, and that was all she talked about. That's what got her hospitalized. She was actually functioning pretty well outside the hospital, living on her own, and she started calling the police and the FBI and the Supreme Court and everybody to get this guy arrested. And her first call was investigated and taken seriously. They realized she was delusional. And this is all she talked about. And our eventual treatment outcome was not any reduction in her belief, but instead she decided her value was justice, and she had done what she could to see justice was served, and now it was time to move on with her life and attend to other things that were equally or more important to her. And she just started talking about the delusions less and less as she started focusing more on like a job she wanted to get and getting out of the hospital. I don't know how much her talk initially affected other clinicians' treatment for her. It depends. Like the psychiatrists, definitely, they're going to adjust medication based on that. There might be daily nursing reports. So it's going to depend on the institution. And I'd like to see more training of staff. And what's also kind of interesting is an older study, 93, Miller and colleagues. They looked at the pros and cons of delusions, and they looked at a sample of, I think it was 100, and they found that 98% said delusions have negative consequences voices, I'm sorry, it was hallucination. Hallucinations are bad. They make it hard for me to concentrate and focus. They say mean things about me. People think I'm crazy when they know I have voices. But interestingly, half of the sample also said there were good things about voices. They keep me company. They give me reminders, like don't forget to take your medication. They say nice things about me. So it's also like looking at this view, is it entirely a negative thing? Is this something you must get rid of? And I don't think most of us would think of hallucinations as like having potentially positive consequences. But in these cases, it's like, well, maybe we don't need to get rid of them. Maybe it's perfectly okay to have hallucinations. Yeah. Mhm. Yeah. Mhm. Yeah, with this idea that I think it kind of reflects some inherent bias or stigma with looking at psychotic disorders, because it doesn't sound objectionable to talk about the content of someone who says, let's say, someone with social phobia or depression who says, I'm a bad person. Like we don't worry that, oh no, they're going to go out and tell everybody I'm a bad person, and they're going to be all about, let me tell you how bad I am. But we do seem to worry about that with delusion. Like if we talk about it, they're going to talk about their paranoia and nothing else. So I think that some of that might be our own biases about working with this population. And this is probably be an interesting data collection, but I think a lot of clients who do talk about their delusions a lot, or with a disorganized speech, I get the distinct impression that it's operant, and it works very well for having clinicians go away and stop asking you to participate in a group you don't want to participate in, where I found often if I just sort of ignore it and go on to the next question, the disorganized speech stops, or the talk about the delusion stops, and they see I'm not going to say, all right, I'll come back to you later, that I'm going to stay engaged, and they stop that right away, where I don't know how frequently that's the case, but I have the impression it's often, it's sometimes the case, that what works is to keep talking about the delusion, because then people leave you alone, or whatever. But workability is definitely the way to go. And maybe in session we're talking about their delusional content, but it's some of that is about, and how workable is this for you to focus on that. You know, just little anecdote was a client who would, he was worried that other people thought he was crazy, and so he would stop taking his medication, because crazy people take medication, and there's that maybe faulty conditional reasoning. Crazy people take medication, so if I don't take medication, then I'm not crazy. But of course that made him even more delusional, and then he was even more likely to be thought of as crazy. So we kind of looked at the workability of that whole system of I don't want people to think I'm crazy, and looked at what other values there were in work, and kind of he just sort of naturally drifted away from that being one of his major goals. But I agree that workability, rather than arguing is this real or not, like we could have argued about whether or not other people think he's crazy, but it's for one, it was sort of, if you're not willing to have it, you got it. We could look at it that way, and like with any client, workability is where I think we hook the client more than arguing about content. Yeah. Yeah. Yeah, and it's very easy to dismiss those groups as paranoid. And it often is individuals who would have the diagnosis paranoid schizophrenia who lead those sorts of groups that are like, stay out of, you can't tell me to take medication. So it is interesting. I'm really kind of glad to hear that's coming up as a civil rights issue, because it is simple to dismiss it. And I think there is some sensitivity to that as a civil rights issue. I'm a colleague with Pat Corrigan, who does a lot of research on stigma against persons with mental illness. And we run into with what gets tricky is where it's political correctness, in the negative sense of the word, and where it's respecting self-determination. And like we went through, we see patients and then clients and consumers and users, and participants and the stuff that just starts seeming almost silly. I think, Steve, that you've written some stuff on the listserv about how these terms, the new term gets all the baggage of the old term, so then we say, oh, we need to change it. One issue that is being addressed increasingly is the right to self-determination, that I get to choose what treatment I want to participate in and whether I'm going to participate in if I want to take medication, and that is a new development at least in the United States. So it's just starting, and it's with those folks like Pat Corrigan who are interested in stigma, and where they're looking at how stigma affects the quality of life of these individuals, that it's not just their symptoms that affect their quality of life. What they add, like the classic diathesis stress model is, I have this diathesis or genetic predisposition, add stress and you get illness. And what Corrigan added is stigma, that it's diathesis plus stress plus stigma that leads to impairment in functioning. So it'll be interesting to see how this plays out, and I think it's a very valid point. In the state of Illinois, we had a recent law, a change in the law on involuntary hospitalization, and it was spearheaded by family members that basically allows family members to recommend involuntary hospitalization for people who under the old laws would not have met criteria, where it's basically saying, Johnny went off his meds, and I know whenever he goes off his meds, he gets totally out of control. So hospitalize him now. And it passed, and there has been this change in the criteria for involuntary hospitalization. And I can see both sides of it. I think it's a very hard issue. I think that there is I agree that there's a real civil rights issue in there, and I think it's a complicated one. When you say the end of the continuum, what do you mean? You said IRB aside. So are you saying, could we make people crazy? Or yeah. Oh, I'll bet you absolutely could. I always think that, it's sort of a thought experiment, since the IRB won't approve that. When in teaching psychopathology and physiological psychology, I'd like to point out that in theory we could test all these things. But we'd have to start with an experiment that would start with, we separated these children from their parents at birth and raised them in an environment, or we separated these twins, and one got the good nurturing home and the other got the abusive parents, where it's just stuff that'll never be done. But in theory, we could do all of this, and I would predict, sure, we could do that. It sounds like you're clear, but I'll just reiterate. I do believe there are biological deficits in schizophrenia, and that that there might be a biological deficit that leads to impaired conditional reasoning or impaired perspective taking ability. I mean, we see structural brain differences. Where they're doing the flip side of that experiment is in the United Kingdom, where they're identifying people who have a strong genetic predisposition. And apparently at this point with MRI, if you look at like 12, 13-year-olds with, let's say, two parents, parents with schizophrenia or siblings with schizophrenia, they can identify with very high accuracy. I don't know if it's 95 or 99%, but very high accuracy who's going to later get schizophrenia. And they started a study. I haven't seen, there's probably interim data out at this point, but it's at least 5 years ago, where they identified kids around 12, 13 who would be likely to develop schizophrenia, and they're giving medication starting when they're 12 or 13 to see if they can prevent schizophrenia. And what might be interesting is to see if you gave something like ACT to these kids at 12 or 13, could you prevent schizophrenia? But I'm sure we could, because if we look at the conditions under which people without otherwise having a disorder have delusions and hallucinations, it is things like sensory deprivation, sleep deprivation, where it's not that hard to induce delusions and hallucinations. It really doesn't take all that much at all. It's sensory deprivation, but it doesn't take a very long period of it, or a very long period of sleep deprivation to create those conditions. Yeah, and PTSD, definitely some of the re-experiencing symptoms are like hallucinations, or I'm not sure about delusions, but definitely hallucinations. And that would go back to Macher's theory that bizarre experiences demand bizarre explanation. It's sort of like where he looks at delusions often function to explain hallucinations. So the person who is hearing voices says they planted a radio in my head, because how else would you explain voices? But he would also look at this in unusual circumstances where we might develop symptoms of psychosis, as because we don't know how else to explain the situation, is basically what he would say. So we might develop some delusional belief in order to explain this anomalous event. And I always forget the name of the woman, but they name a syndrome after her, and it's basically the person who's thought to be delusional who isn't. She believed that her home was being bugged and that people were following her, and was eventually brought to the attention of some type of treatment provider. I don't know if she was hospitalized or not, but described as paranoid, and it ended up her husband was a central figure in the Watergate investigation, and they were in fact being bugged, and had people following them. And I know we had an individual in my experience who was hospitalized, and they said, like, I'm a doctor, and everyone was like, yeah, right, and in fact the person was correct. Or I'm the ambassador to some other country, or my brother's the ambassador to another country, and in fact they're telling the truth, and it's our misattribution where we say it must be just a delusion. So just attribution's a funny thing. And as our experiences get more bizarre, it makes sense that our explanations for what's going on would get more bizarre. And that's, I don't know what this means in terms of free association, but you always find religion is on that, in that, gray area, right in between, like when do we call someone's beliefs delusional and when don't we? Where you look at something like belief in voodoo, in most areas in the United States, if someone came in believing a voodoo X was placed on them, they'd be labeled delusional. In a lot of parts of the world, they wouldn't. And so definitely our experience will shape that. And I think shared psychosis is a good example too, where you learn the delusion, basically. Shared psychosis is most often a first-degree relative of someone with schizophrenia. And they come to share the delusion of the person just because they're raised in an environment where they're taught that that is normative. And you can see someone in a socially impoverished environment or where they're being directly taught that X is true, might come to hold a delusional belief or to have impaired perspective taking. You hold the microphone a little closer, I can't hear you. Yeah. With metaphors, it's used physical metaphors as much as possible and simple ones. So you're doing like a demonstration in the room. So you might say, instead of your thoughts about your paranoid thoughts are in the way, or they interfere with hearing other things. So instead, you might write down some paranoid thought on a piece of paper, as I'm doing right now. Probably writing it too small for this purpose, but say, now these thoughts are in front of you, except that would be facing the client, that they're out to get me, and how that gets in the way. Notice that you can't see anything else when you're focused on, they're out to get me. And so it's just like we might do that with any client, not just a client with paranoia. But it's bringing those physical accompaniments, so we're making the metaphors a little more physical. Or if I like one called the ball and chain metaphor, and it's useful with clients with stigma, and it's imagine you have a ball and chain around your leg, and I won't just what's where this video camera's funny because I can't stand up and demonstrate it. But I demonstrate, I'd walk like someone who has a big ball and chain around their leg. Say, and notice that, if your goal is to get far away from that ball, what happens? How can you move? And notice that it's really hard to move. And how would it be easier to move? And usually it's if you pick up the ball and hold it close. But what I love about that metaphor, I learned it from J.T. Blackledge, by the way, and he used it in the context of parents of children with autism. And it's that it's still harder to move than if you didn't have this burden at all. It's hard if you're carrying a 50-pound ball. It's harder to move and I like it to acknowledge that the client has this thing that other people don't have, that this burden they have to carry around. But it's still easier if you hold it close than if you're dragging it behind you. And if you want to make it even more physical, like DJ Moran, instead of using a ball and chain, he'll just grab a computer back, and my computer isn't handy, but if you're holding it like this, it's harder than if you're holding it close. It's harder to move and do what you want to do, but you bring these physical things to demonstrate your metaphor. I'll do one called A Shrinking World, and I use it with clients with any disorder, almost every client, especially anxiety, but also clients with their paranoia, where that's getting in the way. But it's I'll just throw pieces of paper around the room and say it's like your anxiety or your paranoia saying, don't go there. Don't go there. You can't step there, and pretty soon the whole office will be covered with paper. And it's like that's what your world has become. You have nowhere to go. So it's just adding the physical part of throwing the paper out there just makes any metaphor easier to understand. But the observing self, I don't believe, or it's not my experience, that you can do that work with every client with a psychotic disorder. And a client who's floridly psychotic, I'm not going to do much of anything. I'm going to say, let's meet at another time. But the mindfulness piece, I think you can do with the observing your thoughts, and I haven't experienced that very often. Well, I personally haven't ever experienced it, and I know that Steve. Now I'm Fran Scheuer, right? And Farhall, what's his first name? John Farhall. They report an experience of someone having like an adverse reaction to taking your mind for a walk, but that it was a one-time occurrence, and they were able to talk to the client and calm him down, and it's not like he spun off into a psychotic episode. He was distressed at the moment. But the observing self-work, you can also approach with kind of physical metaphors, where you say, you make it more physical anyway. So you say something like, here you and I are sitting in this room, and imagine you were an observer looking in. What would you see? And you get to observing self that way, where you have the client act as if they're observing themselves. But the observing self exercise, like as it's written in the ACT book, is difficult to do with clients with psychotic disorders. So you're going to be limited to higher functioning clients to do that. And more often, higher functioning is defined by the degree of negative symptoms. Like I find clients with paranoid schizophrenia are usually higher functioning in terms of intellectual ability, cognitive deficits, negative symptoms than most other clients. And those clients you can do the self as context work, but other clients less so. Uh-huh. Right. Yeah. Yeah. Uh-huh. Uh-huh. Yeah. Yeah. Yeah, no, I haven't done training, and I think that's a great idea. And my prediction would be that we would see some positive benefit to doing direct training in this kind of relating, and it would be easy to test. You know, it would be something easy enough to do direct training with these kind of questions. And in the theory of mind literature, there is a whole lot of tasks that are used to directly train theory of mind skills. And and I think even in lower functioning clients, you could do some of them. In the again theory of mind literature, they break them down into levels where they look at like level one as just I see something different than you see, and that doesn't even require RFT. I mean, we can see that with animals, and it's condition relating for sure, but it's not arbitrarily applicable derived relational responding, where you'll see dogs are actually very good at it, and higher primates, where they will learn to look where somebody else is looking, like follow their eye gaze. And that is a kind of perspective take, where it's getting that you see something that I don't see. But it's, again, not like you have a perspective, it's not RFT, or I mean, you can understand it in RFT, but it's not derived relational response. But it is condition relating. And then there's getting that, again, kind of still in the visual perspective, that different individuals have different visual perspectives, that you might not see what I see, or you see what I see differently, kind of like that classic joke about the three blind men and the elephant, that they have different experiences of the elephant. And then there is, you start bringing in the other perspectives, where they'll usually have a task where they have like a box of crayons, and they show a child, this research is more common with children, we could do this with adults, they dump out the crayons and put in candy, and then they say, now if we bring this other person in the room, what will they think is in the box? And the right answer is crayons, that they weren't there to see you put the candy in the box. And then there's the next level is that other people can have false beliefs based on their history. So it might be you show a child, two children, and you show one that you put candy in the box, and then you have one of them leave the room, and you put the crayons back in, and it's like, what will the person believe? Well, they'll believe you have candy in the box. They have a false belief because conditions have changed since they left. So you have to be here now to get to make the right response there then. So there's lots of training. I guess my point is probably a long-winded way of just saying there are lots of training protocols out there. And there's Dermot Barnes-Holmes, which is the questionnaire. That's just I have a red brick, you have a red brick. If I was you and you were me, which one would I have? I would guess we'd see some improvement in ability to do perspective taking. And the other piece of the question on the negative symptoms, I think we want to bring in more like behavior activation. And then it gets a little controversial with the self-determination, but also medication adherence, which might indirectly have an effect on negative symptoms. As I already mentioned, medication more often affect positive symptoms, but there is some evidence for an effect on negative symptoms with a few of the newer ones. And what you have to pull out is the ACT literature on, but I guess the other piece that would interest me is, can you increase treatment adherence to psychosocial interventions? Where I'm working on a little project and also putting together a grant, and it's Pat Corrigan works with these agencies a lot more than I do. He points out you've got to be careful when you say, well, this works with behavioral medicine populations, because you have to acknowledge that, but they don't have the deficits. But we have lots of evidence that ACT improves treatment adherence. You know, we see that with like the diabetes work and the asthma work and the behavioral medicine, generally the pain work, that people show up, that they follow the psychosocial treatments as well. So I think that's another place, treatment adherence. And I think what would be important to me, but what you might sell to funding agencies, is it'll increase medication adherence. But I also want to see an increase in adherence to vocational skills training and skills training groups and so forth, where that's where I think ACT can really be useful, because we know that skills training works in people with schizophrenia. Right now there are, I think, 5, might be 6. Yeah, there's 6 including medication. Kind of evidence-based practices or empirically validated treatments, whatever they're calling it, for schizophrenia. One is medication, one is supported employment, one is family interventions like focusing on communication skills training, and sort of community treatment, and psychosocial rehabilitation, and that's skills training. And why not treat perspective taking as just another skill? Like, in addition to social skills training is usually the protocol I've used is how to start a conversation, continue a conversation, end a conversation. What if we add perspective taking to all those other kinds of skills we train people in standard treatments for schizophrenia? But it's also selling them. And I think it's partly a problem of stigma that these groups aren't as different as you think from the other groups that benefit, and it's partly tailoring it to this group, like acknowledging that there are some differences. Oh yeah, I think you could get like a practice effect for that. Like if you just use that questionnaire, sure, it would be kind of like, I guess trying to improve someone's vocabulary by just giving them one list, where we want to do some generalization in there and have different kinds of perspective taking tests, and then probably you determine what your outcome measure is going to be. Like if your outcome measure was that questionnaire, you wouldn't want to use it as part of training. You might just give it pre-post, but do some other kind of training. And you're also thinking, I guess, when you remind me you're a behavior analyst, I also want to point out that there's some work in autism that says that you can shape up perspective taking, and that it does lead to some positive outcomes in terms of generalizing to other areas of social functioning. I think it's been mostly case studies. Steve might know more about it than I do, but when you think of like autism, often used to be regarded as childhood schizophrenia, and where we definitely see impaired perspective taking in that population. I know there's some data out there on RFT and directly training perspective taking as a way to improve social functioning. That said, so far, what I've heard has been pretty positive, but again, it's been case studies that I'm aware of. So I don't know, Steve, if you know of any more about that. Yeah. Mhm. Yeah. Right. And I'll add a conditional relating too. We could, shaping up that. Yeah. Hmm. Yeah. Uh-huh. Yeah. Yeah, and this work is happening more in the area of child development and developmental disability. Like Ruth Ann Rayfeld's volume on, it's kind of applied RFT. I think if you read that book, it would already give you ideas of where you'd go, and you just have to tweak the protocols a little bit to be more appropriate for adults. Yeah, and these kind of the more clinical psychology versus where the behavior analysts you see more in the developmental disabilities and autism work, and there the twain shall meet, and the RFT is just one area where it really does meet, kind of dovetail. Yes, yeah. Hmm. I think that is still true in the United States, but in Europe and Australia, you definitely see more emphasis on psychosocial interventions for schizophrenia, and I think it's a difference in the healthcare systems, and maybe also a difference in clinical training, or, well, I guess the two are related, but the accessibility of psychotherapists who are trained to treat serious mental illness is related to the structure of the healthcare system. But I'm most familiar with the United Kingdom, but I believe it's somewhat generalizable to more of Europe. You'll see more clients who have schizophrenia or are treated for schizophrenia will just have exposure to psychotherapy, where in the United States our focus is more on medication. And what we find, like I mentioned, treatment adherence, or no, I mentioned a number like 75% of clients who take medication um, don't find it, that you still have symptoms. But if we look at treatment adherence, it's awful. That the person, there's a study, the Katie study, catchment area, I don't know, it's basically a study of how well do people adhere to antipsychotic medication. Awful. Most quit their medication. And if you look at adherence to psychosocial interventions, it's even worse than for medication. So it's also how do we keep people connected with services? And that's also a problem with our healthcare system, that the system in the United States just isn't well structured to have an emphasis on keeping people in treatment and linking them with the services that are best for them. We have a kind of fragmented system where, like, just thinking of systems I'm familiar with, kind of locally, clients can get medication pretty easily, generally, in order to receive, like, for no cost. In order to do that, they generally have to also be involved in case management or therapy once a month. So very often you'll get clients who come there once a month minimum, and you're not going to get much therapy done. And also you still don't see a lot of training programs for clinicians giving therapy with psychosis. You mainly hear you can't do therapy with psychosis, so there's just not much motivation for clinicians to learn that. But in Australia and Europe, it's a different story. That's where there's much more research going on psychotherapy. So I think it's still the forgotten child here, but not everywhere. That's because you're special and I'm psychic. Uh-huh. Yeah. Oh, I think tolerance for ambiguity is something we're doing with lots of our clients, not just clients with psychosis. You know, like when you mentioned cultivating tolerance for ambiguity, I think the first client who comes to mind is my client with social anxiety and just ambiguity about what other people think of him and tolerating uncertainty about, you know, did I say something stupid and do they like me? And it's just building that willingness to have our thoughts that show up. But the attributional biases, it's almost a two-step thing where we all have the attributional bias that we seek out information that supports our belief. You know, the fundamental attribution error and confirmatory bias, where the confirmatory bias is we're all inclined to seek information that confirms our belief and dismiss or minimize information that disconfirms our belief. So that's something we'll be dealing with everybody, and I think one little piece of it is just psychoeducation, like just pointing out that we hold that bias. But I think there's data that says even after you tell people about the attributional bias, they still commit it. It does have a little bit of an impact but and I shouldn't even say they, I should say we, because we all do this. But the hostile bias is that it says that it is also a bias that is true for most of us, that when someone does something negative towards us, like there's a negative event, we're likely to attribute it to a negative intention on the part of the person. So I'll always kind of as an everyday example, like let's suppose you wave hi to your friend down the hall and they ignore you. We're more likely to think, what did I do? Are they mad at me? Before we think, oh, he must be preoccupied. I hope he's okay. And that the theory applied to schizophrenia says that what's different is access to negative events, that these clients are more likely to attend to negative events in the environment. So we might all have that bias that when something negative happens, we attribute it to the negative intention of another person. But it's saying that the person with schizophrenia has easier access to negative events. And I suppose maybe that's where the perspective taking training, or there they look at it as a problem of autobiographical memory. But I think to a certain point, the behavioral experiments work, and because they also require exposure, where you say, let's go outside and see what happens. But I think that's where you really need to bring up the workability and values to get, because it has the same problem as exposure and response prevention for OCD. You have a really high rate of unwillingness to engage in it at all, and then you have a really high early dropout rate because it's aversive. So you have to build up willingness to do this, but then just exposure goes a long way towards seeing that, oh, nothing terrible happens when I go outside. But the disputational techniques are looking at alternate explanations for the thought. But I think we are moving away from ACT when we do that, when we do like disputation. But I do again think behavioral experiments can, frame it as exposure. Let's go outside and walk around the block and see what happens. I think community-based interventions are great for clients with schizophrenia. I think that's largely why assertive community treatment works, because it takes place in the community, so you get lots of opportunities for exposure and generalization. Not sure if that answers your question.
Yeah.
Yeah. Mhm. Yeah. Mhm. Yeah. 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 That expressed emotion research is where the family interventions come into play. I think expressed emotion is a funny term because it sounds like too much emotion is bad, you know, and it's really more an environment where there's too much negative emotion and criticism, and often somewhat intrusive behavior, like constantly checking in, are you okay? And there are some interventions on teaching families just problem-solving skills and increasing the kind of percentage of positive versus negative communication. And it's really that simple. And it's what that could certainly be done as prevention. If it works once the person already has the problem, it could certainly be added as prevention. And when you talk about like clients who need, you know, like does emotional avoidance cause alexithymia or does alexithymia cause avoidance, you just reminded me of a client. She was 42 years old and had been in a residential facility or hospital since she was 22. And the staff was basically like, you know, her life is pretty much over. And I was just so outraged where this was half her life. You know, she's 42. She's got half her life left to live. And they were pretty much saying like, it's over. And you wonder, because these clients, you know, many of them were in college when they had their first psychotic break, or working and had useful skills and things they enjoyed doing, and maybe were married or in relationships and had families. So it's certainly somewhat of a, not just a skills deficit, but a loss of skills. And the interesting international data and national says that people with schizophrenia do better in rural areas, where you find the incidence of schizophrenia is about constant worldwide. But individuals do better in rural areas, and it was thought that the early interpretation of that was that people with schizophrenia gravitate to the city, and that's why you just see more in the city and they do worse. But the more current interpretation is that in the rural communities, they're provided with more of a useful role in society. That if you go to some, say, little rural town, Crazy Joe has something to do. People hire him as the handyman. They're friends with him. They talk to him. They invite him to the social gatherings, where in the big city, that person is not acknowledged and they don't have a useful role, and they're not treated well by other members of society. So I think it's also just public education, and that's where like the anti-stigma work goes in changing attitudes towards people with mental illness. Okay. You know, I really don't. This was a lot of fun. It's interesting. It stimulates my thinking for sure. I'll briefly mention, since a lot of you will be at ABBA, that Pat Corrigan will be talking there about stigma on a talk called Don't Call Me Nuts, one of the Skinner lectures, and looking at this area of stigma. And I think, and I guess that will be my concluding remark, I think stigma as an area with a lot of promise, both looking at treatment provider stigma and how it maybe keeps us narrowly focused on treatment, stigma of the public, and how it limits opportunities for people with mental illness, then also self-stigma. And I think self-stigma is an area where ACT can really be useful. But thanks. I'm looking forward to seeing you all in Reno in June.